Okay, well, it's another episode of Khalidiyya, and we have a special guest today, Dr. Goleen Samari, assistant professor at Columbia University. A number of accolades. If you'd like to introduce yourself.
Sure.
Your resume is longer than we need to read, but it has a lot of
Sure.
Yeah.
Happy to. I'm Goleen Samari. I'm an assistant professor at Columbia University's Mailman School of Public Health. I met Khalidiyya through our graduate program in Islamic Studies. So I have a background in both Islamic studies and public health, and I'm a population health demographer by training. And so I kind of use that combination of training and skills to really focus on social inequities in health when it comes to Middle Eastern and Muslim populations, both in the US and in the region. And so I'm probably most known for my work in that space.
I have sort of an irrelevant question, but what is the mailman part of that? Like, I saw that earlier.
I think they name schools based on donation amounts.
And there was a mailman.
Someone named Mailman.
There was a mailman that donated to the school.
Yep, that is what it is.
Yeah.
Like the UCLA school where I graduated from was the Fielding School because of Jonathan Fielding's donation, so it was named in his name.
Sure. I mean, I get that. I just like is mailman a name, or is that a title?
No, it's a last name.
Mailman?
Yeah.
That's an unfortunate last name.
I mean, there's worse though.
Yeah, I suppose. Hey, we recently talked to Ronnie, and we met Ronnie when we were in Beirut. We lived in Beirut, and when I was your chaperone and translator.
You were my chaperone in Beirut in what, 2010?
Yeah.
And we met Ronnie.
And we met Ronnie, and I also did some data entry, I recall.
Oh my gosh, you remember?
For
that we lost that survey data and you helped re-enter it.
Yeah.
At AUB.
Yeah. So I lended a hand.
Yeah, you sure did.
In any case, so we go back a long ways.
Yeah, more than a decade.
There's a lot of history there. But it'd be nice to talk about what your current research is and what you're working on currently.
Sure. Yeah. So I, as you know, because we go back so far, used to do quite a bit of work focused on women's health. I still do quite a bit of work focused on sexual and reproductive health. But in 2015, when I finished my PhD and was getting started on my postdoc years at the University of Texas at Austin, I noticed that there were a lot of anti-Muslim hate crimes going on that year. In particular, there was a murder of 3 Muslim students at UNC, and then there was the incident with the bomb clock in Dallas, with the kid taking a clock to school and being accused of making a bomb and being expelled. And it just really dawned on me that I was sort of positioned in this place where I had had training from a lot of scholars who had looked at racism and health, and I also had Islamic studies training. And so I was like, I'm one of the few people that's actually able to speak out about why Islamophobia and anti-Muslim racism is really a health issue and a public health issue. So since then, I've had sort of an ongoing line of research in that space. And because the research is so limited, I did like sort of the theorizing and the conceptualization. And now I do a lot of work that really tries to like measure it and quantify and really operationalize it. And so a lot of my current work is really, using tools that we have available to actually like capture what's going on and really show people that it has a health impact. So I had a recent paper that, for example, looked at the 2017 Muslim ban and how it affected women's birth outcomes. And there was a real big increase in preterm birth among the women from the banned countries, which is a terrifying health indicator because we know that that is a predictor of lifelong health and poor health. And so just this one really structurally discriminatory policy had a profound impact on women's health. And so I do stuff in that space, and along the lines of other social inequities in health. So I look at migration-based inequities, particularly in the Middle East and North Africa, and I continue to look at gender-based inequities as well.
So for someone who's not in your field, what do you mean when you talk about quantifying it, and like what is that exactly? For someone that doesn't know anything about that particular field.
Sure. So like a lot of times we talk about like measuring things or, proving things. And in social sciences, we have sort of two ways that we create proof or show associations. And one of them is through quantitative research and one is through qualitative research. And so I do both. Qualitative research is really asking Muslim communities in the US about their experiences with discrimination, what they do to combat discrimination, how it affects their health, how it affects how they socialize in the world. And so it's really bringing those voices forward. On the quantitative front, it's really about different ways of measuring it. So for example, a lot of our hate crime statistics are from the FBI, and they're imperfect because of the way that we talk about race ethnicity or measure race ethnicity. So for example, a lot of Muslim communities are categorized as white because Iranians and Arabs are categorized in the white category. And so the hate crimes, like if you just look at raw hate crime statistics, you don't have a full picture of exactly how many anti-Muslim sort of hate crimes there are. I think it's really underestimated. And so I try to capture like, how can we measure anti-Muslim hate in other ways? And so one of the ways is like scraping data from Twitter, for example. So like, are there periods of time where there's more like hateful tweets? Is there Google Trends data that corresponds to increased hate? Using different tools like that to actually create sort of quantifiable numbers around these things, and then associating them, using statistics to then associate them with various health outcomes.
Here's a question in terms of the quantitative aspects of the research pertaining to Muslims in America. Obviously, we know that there is no set number. We don't know exactly how many Muslims live in America. Because of what you had just stated. We don't know how many Arabs or Iranians or what have you of the different groups are in the country. And so one, how does that affect your research? And two, I mean, yeah, you said you're coming up with other ways to try and quantify data. Is this, which is pretty creative. I mean, that sounds very creative. Is it are you able to use that data in as effective a manner as if you had the actual figures, like official figures?
So a couple of things on this. It kind of goes both ways. So one, you have to be creative because there's no official figures. And even beyond something like the census, which is our closest thing to like an official count. And there was a big debacle with the census data collection in 2020 around Middle Eastern and North African communities. And we can talk about that further, but basically the decision was made not to collect that identifying information. And so what happens is a lot of the survey information, so they take a sample of the population and they survey them. is based on the census racial and ethnic category. So even the nationally representative survey data that we have doesn't really capture religion. It doesn't capture Middle Eastern and North African categories. And so you have to be really creative. And I've used some national data that we have to like do some of my work. But again, you often don't know within the Arab community who is Muslim and who is not. Same thing with the Iranian community, even if you can identify those communities. The other side to this is within these communities themselves, there's a certain amount of vigilance and I don't know, like lack of desire to reveal your identity because of experiences of hate and discrimination. And so on a research side, for me, it's a constant battle between, do I push for identifying these communities? And how do I do that in a way that sort of, there is a certain level of paranoia now in all of our communities about revealing that kind of information, or, you know, it's kind of a 50-50 split about people who want to be on the census versus not because they prefer to be hidden. And so that's a result of the discrimination as well.
Well, I mean, this is not a new, in my understanding, this is not a new situation. The reason that Arab Americans are considered Caucasian on the census, they campaigned for it because it was in the 1920s or so, around then, that they, during like Jim Crow laws, that they didn't want to be classified as non-white. So they campaigned to be considered Caucasian, but now it makes them basically invisible on in the census as a distinct community. And then also, like today, I think there's just a paranoia about talking to the government whatsoever and identifying yourself. And I understand the logic for each of those you know, impulses and those movements, but it does make it very difficult to quantify those populations and demographics.
Exactly.
Well, I think,
and that's 100% correct. Like this movement for being included in the white category started really early on, and now I would say the communities are pretty divided. Part of the problem is that their lived experience is that of a minoritized community, right? So most Arab and Iranians and other Middle Eastern groups are not walking around the United States being treated like white people. And so I think that that's where the debate comes into play. And it's really, really tough as somebody who wants to advocate for these communities and have resources allocated to these communities to then not have the official count. But it's also equally respectful to not want to reveal your identity based on the experiences and want to remain a hidden population. And so as part of the respect for the community, I also hold that really, really closely.
well, I have a friend who he's an activist in the Arab community here in Southern California, and any sort of political issue that pertains to the Arab community, he's pretty much at the forefront of that. And so he was very active in campaigning for the prior to the census, the 2020 census, to get those categories recognized. And he was going around the community and informing people and doing all the legwork, right? And telling people that, hey, yeah, we know of the paranoia factors. We know of also some of the issues that people have that they've carried along with them from, you know, a lot of them from countries where they come from authoritarian regimes, right? Where they're terrified of identifying themselves and being monitored by intelligence services and what have you. But what he was saying is that, you know, ultimately this is such a hotly political issue, in that, as you just mentioned, a huge amount of government funds and resources would be dedicated to, let's say, the Arab American community or the Iranian American community or other communities. And those those funds, those resources could be used in so many ways that could benefit those communities. And it seems like, I mean, I can see also from your angle the public health aspect, but then there's so many ways that these communities are held back. And it seems like it's just this concerted effort, to keep doing that. I don't know if it'll turn around in the next census, if things come around, but.
Yeah, it's happened like every census for the last like 30 years. So I was really hopeful for the 2020 round. I thought that it was finally going to go through. And so because of a lot of those grassroots efforts that you're talking about, because of a lot of the information sharing around what it means for resource allocation for these communities. And unfortunately it didn't. And I think it ultimately didn't. There's like a 100-page report out of the Census Bureau about, everything they did with piloting these measures, and basically all their evidence shows that it was useful for these communities to have this categorization. And then ultimately it didn't move forward. And I think that was very politically motivated and outside of the research that shows that the utility of actually having that additional category.
Well,
right.
Here's a question outside of the academic world, because I mean that's the orbit that you're working in. How does your research how does that translate into impacting policy?
Sure, it's a great question. So my first realization that this argument that anti-Muslim racism leads to poor health was an academic argument that the public could not fully grapple with was when I wrote the original piece on this in 2016, because I also published an op-ed in order to, a lot of times with like pushing policy forward, you have to not just publish an academic article, like certain people care about that, but not everybody does.
No one reads academic articles except for academics.
Right. So you have to publish op-eds or policy briefs and things like that, and really connect then organizations that are doing policy work to your work to move it forward. And so I wrote an op-ed, and then I received the most hate mail and death threats and Islamophobic directed like hatred that I've ever received in my life following that op-ed being published. And my argument is very simple. Like we know that racism affects health. We have decades of research in the health space that shows that. Muslims are people too. And so racism against Muslims affects their health as well. That's the whole argument. And people the public could not get on board with Muslims are people too. That piece of the argument really was triggering for a lot of folks. And my family received hate. The FBI had to get involved. We had to stop checking our mail. It was quite a fraught situation, but a learning experience for me, which is that the academic argument is one thing, the public opinion argument is another thing, and then the policy effort actually involves taking all of that collective information to organizations that are doing this policy work, both at the local levels, because even in states, we have like anti-Sharia legislation. And one thing I look at, for example, is, states that have more like anti-Sharia bills being proposed and passed versus states that have less, and thinking of those states that have more as more hostile towards Muslims, and using that sort of structural information to look at Muslim communities in those states and their health outcomes. And so there's a lot of policy effort that can take place at multiple levels, and a lot of it is getting the research in the right hands or partnerships with organizations that are doing the policy work.
Well, you're up against a lot of morons. Like anti-Sharia laws, it's like you don't even know what that is.
Exactly. I have to always explain to people like where that
like what Sharia
growth.
is.
Yeah. I was
what
like,
it,
that
what it
doesn't
even
make any sense.
means, and
Right.
and no one's imposing this on you. And don't worry, the Taliban is not in your neighborhood. Calm the fuck down.
Exactly.
Well, there's something I wanted to ask, which is, I mean, obviously your focus is on the US, but clearly there are a lot of similarities in other parts, like other Western countries, the UK, the Netherlands, what have you. Are you seeing
France.
that France, of course, yeah,
Yeah.
of course. Are you seeing that, you know, there is more possibility for the kind of work that you're doing, and the things you're pushing for here as opposed to Europe? And like, what are the similarities? What are the differences that you see?
Yeah, so my work is really moving in a sort of comparative direction, I would say. So bringing in some additional country context, comparing. A lot of the theoretical work is applied now. People who are sort of extending my work are looking at European contexts and how they vary or confirm. I have collaborators, for example, who focus on Australia as another case. So it's both moving in the comparative direction, I would say, like also in the demographic age group. So like, what are the implications for youth and the elderly? And so thinking about it like that too. So it's going to be a lifelong effort, I think, but for sure, Islamophobia is not limited to the US. I would say China and India are like global leaders in Islamophobia. And so that it's important to really kind of continue to elevate that it's a global phenomenon.
Well, when we talk about, you know, the health aspects of, or the health impacts of Islamophobia, you mentioned a great example of women from the, like, because of the Muslim ban, women from those countries having preterm births. What could you give like a, I know there are probably like so many different kinds of impacts, but could you give the listeners some kind of idea of like other health impacts as well?
Yeah, so we have quite a bit of work in the mental health space about the impacts on mental health. So everything from depression to anxiety to psychological distress and things like that, to even issues with like identity formation and internalizing stereotyping that we see connected to mental health issues as well. So a lot of work, or a growing body of work, has been done on the mental health impacts. On the physical health impacts, we have a little bit less information, which people are always sort of more hungry for. Like we see some evidence of impacts on heart disease and hypertension, some evidence of impact on chronic conditions like diabetes, and then a lot of impacts on health behaviors. Like if you experience discrimination or racism, you're less inclined to engage in like healthy health behaviors and healthcare seeking behaviors. So going to the doctor, getting advanced health screenings, accessing healthcare, feeling comfortable with your physician, like those types of things. So when I talk about health impacts, I'm referring to collectively all of those things: mental, physical health, health behaviors, and healthcare access and utilization.
Have you looked into do you have any data on vaccination and the Muslim community or the immigrant communities? Like, does that affect? Because I feel like, you know, there's different levels of paranoia about vaccinations. Do you think there's something specific to this, to these demographics?
I would love that data. If you have that data, please give it to me. There's a lot of speculation that, and I've seen, you know, quite a bit of talk, not quite a bit, a little bit of talk about how, because we do not have the racial and ethnic data again on these communities, that we don't know anything about vaccination rates and vaccination uptake. And again, this is why that race ethnicity data is really important, because the Muslim community, the Arab community, the Iranian community, these communities are not the targets for vaccination programs and uptake. And so we could be missing a whole segment of the population that is not vaccinated or under vaccinated and has vaccine hesitancy, and we have no targeted programming because we frankly don't know anything about their vaccination rates. And so it's a huge, it shows exactly why this is a problem.
So they're just kind of slipping under the radar.
Yep.
Oh, yeah.
Exactly.
I wanted to ask a little bit about some of the research that you've been doing pertaining to the Middle East, North Africa region. And when it comes to refugees and migration patterns, and how all that impacts people's health, just to give also give us an idea of like an overview of what your research about that is.
Sure. So I am faculty in the program on forced migration and health at Columbia's Mailman School. And that program was originally founded after Rwanda and really is known for training sort of the next generation of humanitarian sort of aid workers. And so as a result of that, very active in refugee communities throughout the world and drawing attention to issues of forced migration and health and refugee health. And so it's both like an honor and privilege to be a part of that program because even before coming to Columbia, I was focused on Syrian refugee health, given that the crisis has gone on for well over a decade now. So my work in the region originally focused on extension of sexual and reproductive health services to refugee women and girls. I would say it's evolved to a lot more than that because, for example, they've been in Jordan in a protracted crisis kind of situation now for a number of years. It's gone beyond sort of emergency response and getting people sort of their immediate healthcare needs and into a like long-term and protracted response effort. And so I look at things that range from, you know, engagement in education, or like how are Syrian children being provided education and what are the implications of that for their health and well-being. And I look at things like what are the decision-making sort of determinants for people to continue migration onto Europe? Like what prevents them from doing that? I've looked at the employment sector, for example. So, but I come at these things looking at them in the way that they intersect with health. So yeah, it's a whole range of research projects in the region, a lot, mostly on the refugee experience in both Lebanon and Jordan.
Yeah, I mean, there's so much that could be done with that. That's such a huge, like broad, yeah, just a field, really. It's almost like a field of its own, it seems like. One of the things that I've always been curious about, and we've talked about this before, but I saw with my own eyes at a Lebanese refugee camp. It was, you know, Syrians who were at this refugee camp in Lebanon, was the amount of kids that the refugees were having, right? And one of the things that was being talked about a great deal was, well, you know, they're in this really difficult situation. Why are they having so many kids? And they were talking about, well, there were activists who were trying to reach out, and I don't know if it was the UN, who were trying to educate or inform the refugees about like birth control methods and all that. So being a host population dealing with very few resources, and, you know, obviously it's a political issue when you have millions of people, like refugees in your country. But at the same time, and this is something I also read from what you, like one of the things that you had written or was interviewed about was that a lot of the refugees in those environments are coming from areas in Syria where they have high fertility rates. So
yeah,
you know,
This is one of
getting-
my pet peeves. So the narrative is often that refugees come in and have a lot of children, and the same narrative has been applied to the Syrian refugee case, but it's actually like a data anomaly. Like if you look at what the fertility rates were before migration, it can give you greater insights into, like, migration is not triggering higher fertility. There was actually like a pre-migration fertility rate that was elevated amongst a lot of the communities that refugees originated from. So actually, if you look at the fertility distribution in Syria before, you see that they're coming from high fertility areas. So I actually think the impact is quite a bit less than people make it out to be. That said, there's quite a bit of literature also on the impact of disasters like hurricanes and earthquakes on fertility rates, and they are often elevated in response to disaster.